All right, thank you. I want to thank the organizers for inviting me and letting me participate in the symposium and including some clinical context to your computational, topic. I'll be talking about the feasibility of artificial intelligence for pathology clinical practice, since AI can also be applied for research purposes. And I am at the University of Pittsburgh in the Department of Pathology. When I took over as the chair of this department about a year ago, coming out of COVID, there were many unmet needs in the practice of pathology. And these are also applicable to other areas in healthcare. There was an increasing workload. We got busier for less reimbursement. The cases were extremely complex, especially in the urban academic hospitals. We have a workforce shortages, no technologists, few pathologists, and less people want to subspecialize. Less medical students, for example, want to become pathologists. Pathology is often marginalized. That's because they work in the basement, they don't have a lot of digital technology, and so they also don't see patients. So people often don't know who their pathologist is. Nevertheless, medicine has advanced quite a lot. Fields like immuno-oncology that require you to move from a qualitative interpretation to a more quantitative interpretation. People want you to count the number of infiltrating lymphocytes and provide cutoff points. And COVID also persists. A lot of people are still burnt out from COVID. So the question is, how do we address all of those? And there's a lot of hype around artificial intelligence. The question is, even in my own area of practice, which is pathology, can AI be implemented to solve these problems? Now, there are a lot of studies like time and motion studies and validation studies and so forth, where people assume that pathologists who work with artificial intelligence will be happier, more organized, more efficient. That's possibly true. When we asked DAL-E to portray what a pathologist would look like with and without AI, you can see that the pathologist who doesn't use artificial intelligence is not in a digital space, overcome by cluttered materials, and certainly doesn't look very happy. Before we look into going into the application of artificial intelligence in our clinical space, you should be aware that there's a lot of resistance from doctors to adopt this technology, not just passive aggressive behavior, but some actively do not want to go digital, do not want to work on a computer with a mouse, and haven't really built up trust with AI yet. But to me, it's a very familiar story to elevator operators in the USA. I do not know if any of you have ever seen an elevator operator in actual practice today, because they're obsolete. So I wanted to share this story with you, which could be extrapolated to the practice of medicine and pathology today. Because when elevators first became commercially available in the United States around 1853, almost everyone still used the stairs because they did not trust the technology. So to get people to trust the elevators, they trained and hired operators who were required to help people travel up and down in buildings. And they were very important because in the beginning, when the technology came out, it was not very automatic to operate an elevator. Someone had to actually open the door, wind and push buttons. And these operators even had to get their license. But eventually the technology got better, and these operators didn't really do much other than accompany a passenger up and down. And that's all they really did. But the game changer was when these operators became obsolete, because one, they went on strike. So there's a workforce shortage, just like we have today. And two, people did not want to use the stairs because buildings had gotten so much taller in the US cities. Their workload had increased, which is exactly the point we're at today. We have a workforce shortage with an increasing workload. Now, a lot of people have worked on advancing the field of computational pathology, and there is an acceptable published definition of computational pathology, which is an approach to diagnosis that, one, incorporates multiple sources of raw data, so multimodal, Today, a lot of us are working in silos, either text, tabular, or image data, but we should be moving towards multimodal data, where we extract relevant information from those data using mathematical models to generate conclusions, and in exchange, be able to use that knowledge to help make medical decisions. And simply put, my definition is just AI applied to the practice of pathology. When I looked at the medical literature using the term computational pathology, as you can see on the left, in PubMed, there were over 300,000 articles that deal with computational pathology. A lot of people have claimed to coin the term computational pathology, but the earliest paper I could personally find was in 1944, where computational pathology methods were used in a rodent experiment. And up to the end of 2023, you can see that more than 13,000 papers have been published per year on this topic. In fact, there was a nice meta-analysis performed, as you can see in the graph to the right. This particular review showed that the number of publications and AI-based tumor pathology research alone has exceeded like 18,000 papers a year. So in my opinion, if pathology does not adopt computational pathology, you would basically become obsolete, kind of like the Kodak factory that never adopted digital imaging. So as a consequence, our Department of Pathology now here at the University of Pittsburgh officially has a computational pathology division. We have faculty who practice in computational pathology. They're closely juxtaposed to PhD data scientists, software engineers, and we even have our own computational pathology and AI center of excellence. And the mission of our AI center is to, one, promote the academics, two, to solve our own problems using AI, and three, in doing so, generate intellectual property. So the reason we are at this inflection point is because digital pathology itself is quite mature. For more than 2 decades, we've had commercial systems that can digitize an entire slide, which we call a whole slide image or a digital slide. And as all of you know, the field of artificial intelligence has also advanced with HPCs and deep learning and now generative AI tools. So when you can apply that technology to digital images, there's a lot of magic that can be performed, which we would like to leverage in the practice of pathology today. So on the left is one of these devices where you can load your pathology slides and they get them digitized. And in the beginning, the number one application was portability. Most people were excited about the ability to scan an entire slide because they were untethered and now they could read images remotely. But I think what is as exciting, if not more useful, is the ability to run applications on those digital slides. And so we have been doing so with a lot of proof of concept products out there and several commercial products, and thus far in pathology, at least one FDA-cleared deep learning algorithm. So you could use artificial intelligence in pathology for these 5 reasons. 1, you can detect rare events, which humans are not very good at, screening slides to look for microorganisms, which are very small, or single cancer cells. You can also automatically quantify features in digital images, which we're being asked to do as pathologists all the time, to count mitotic figures and help grade cancers. The deep learning algorithms are quite advanced now. They can even run simultaneously, and so we can diagnose cancer from a slide and features of that cancer. What is the grade? Is there neural invasion? And so forth. Even more exciting is the ability to train AI algorithms using images to outcomes data. And that allows us to make certain prognostic predictions just by analyzing those pixels, which again is more exciting than just replicating what humans do. And of course, a lot of people use AI instead of a microscope for discovery purposes, for R&D work, looking at biomarkers and as part of clinical trials and so forth. However, in clinical practice, if we're going to use artificial intelligence algorithms, there are some prerequisites to be deployed in the clinical environment. Number 1, your practice has to be committed to going fully digital. It's very hard to convince pathologists to have AI run on images if they won't even make a diagnosis looking at an image on a monitor themselves. So that has to happen. Number two is the histology lab has to be optimized for whole site imaging. And you will see, I will talk about the concept next about garbage in, garbage out. If you do not optimize your slides with the tissue and the staining and so forth, you will run into problems downstream with digital imaging and subsequent AI analysis. The system has to be validated for clinical use. And at this point in time, there are no standard guidelines in clinical practice on how AI should even be validated, but at least it will be the onus of the medical lab that has chosen to use AI. And at UPMC, we have 3 validated AI algorithms for practice. Pathologists don't like standalone systems. They like everything integrated. So one of the barriers for adoption in our setting is if we do not integrate the AI systems with the lab information systems. That's because the vendors don't have good interoperability. We don't even agree on standard file formats like DICOM. We also need some sort of image management system to plug these algorithms in, and that is often lacking, again, due to interoperability problems. And it's unclear at this point in time where AI algorithms should run. Should they run on an external cloud like AWS? Should they run on an internal cloud like Azure in your own work environment? Or should we use edge computing where they require less resources and they just run locally where the images are acquired? At UPMC, we have all 3 types of deployments in practice, which is probably not the best solution, but the vendors have not provided us with a one-size-fits-all. So I'm a strong believer in the garbage in, garbage out principle. If you do not take care of the way tissue is fixed, you do not standardize the way you prepare, stain, and cover slip those slides, and you do not take care of all the artifacts before you digitize a slide, you will have a lot of problems, 1, acquiring that image, and then 2, trying to do analysis. Now, a lot of people have said that larger data sets and with heterogeneous data can certainly overcome artifacts. I'm not sure that is true. I'll share one example with you where artifact on the slide resulted in a false image analysis result. What I'm showing you is a snapshot of a breast core needle biopsy that has infiltrating breast carcinoma. It was stained with HER2. You do not see any stained cells because they're HER2 negative. So this case, when analyzed, should give you a result of HER2 0. However, when the image algorithm was run, it came out as 3+. 3+ means the patient will get treated with a drug such as Herceptin. The reason it was 3+ is because this cover slip has air bubbles, and as you can see, the air bubbles were falsely analyzed as complete membranous staining, which is not true. And because of the false positive, this is an erroneous result, which for now, I have decided when we implement AI at our institution, I will keep a human in the loop until such time as we have more evidence and experience and build up enough trust for AI to operate without humans in the loop. One thing I've learned from our pathology colleagues is AI still is a black box for them because a lot of the way that data passes through multiple layers of a convolutional neural network and the way the data is represented often in mathematical form, statistical approaches to probabilities and so forth, at least for non-generative AI, it's not really human readable and easy for pathologists to interpret. Pathologists are not data scientists. They like morphology. And therefore, presenting the output of an AI algorithm in an explainable manner, which a lot of people like to term explainable AI, seems to be the best option for them. So an example on the left would be overlaying a heat map where color represents probability of abnormality on top of an image. Is very helpful to localize and also then identify any abnormality. Or if you're screening a whole site image that has been broken up into image patches, the patches that represent abnormality can be ranked, and the highest ranked abnormal patches can then be displayed on a gallery, for example, on the left, which you can link to the whole site image on the right, kind of like a GPS. So pathologists seem to like that, and a lot of commercial vendors offer those type of explainable AI tools today. It is also not quite clear where artificial intelligence tools should be inserted into our workflow. If you look at the typical workflow for an anatomical pathology lab today, or labs that are using morphology to make interpretations, on the left, you have your histology making slides and scanning those slides. Those images then are remotely accessible to a pathologist who, if they make the diagnosis from an image, or maybe making a primary diagnosis, not from a glass slide through a microscope, and then issue a report. A lot of people like what is called a first read approach, where the AI algorithm will run on the images prior to a pathologist even looking at them. That allows you to rescan a slide, for example, if it's out of focus or has some other error. You can triage the cases, however you want to set the importance and priority. So cancer cases could go first on your list. You could screen the case, looking for bugs, and even pre-order stains. That's what trainees do in an academic environment, like residents and fellows. They look at this, they look at the case before, screen it, order what's necessary, and even prepare a diagnosis. And so you could do that with AI too. Some people have even proposed that you can sign out all the negative cases. So only refer the abnormal cases onto a pathologist for review. You could also deploy this as a second read. So once the pathologist has looked at the case, only then do they direct the AI algorithm to be performed on a specific task. Like, I can diagnose cancer, help me grade that. I think this is cancer, can you confirm that? Or I'm not sure what the diagnosis is, can you offer me a differential diagnosis, and so forth. I have seen in our own institution where we deployed an algorithm as a second read, and the pathologist really wanted it as a quality check. But after a while, they realized that was a very inefficient approach. And so they had the algorithm then switch to a first read, which introduced much more efficiency. There's also room for artificial intelligence algorithms running in the background. We perform a lot of quality assurance checks in mandatory programs by the government here in the USA. We check various types of cases. We also correlate cases with radiology images. Today, most of that is done manually, very time consuming, and that could all be handled by AI, except no one is working on that at the moment. At our institution, we installed an AI algorithm more than 4 years ago now to analyze prostate core needle biopsies. In the beginning, we were not sure how to validate this algorithm. There were no guidelines. Even when I contacted certification and accreditation agencies, they had no guidelines. They still do not. So what we did in this particular instance was we pulled 100 consecutive cases, which were archived cases. They had approximately 3,000 slides. Those had, retrospective diagnoses, which we considered to be the ground truth. We ran an artificial intelligence algorithm to detect if there was cancer, to grade that cancer, and look if there was perineural invasion, in other words, invasion of any nerves. And we identified 30 slides where there was a discrepancy between MD and AI. We had to adjudicate those cases, and as you can see, there were several false positive and false negatives, and it turned out that all 30 cases, the AI was correct. And here's a typical example where the AI with this heat map had identified an area of cancer, which initially was felt to be benign. However, when this case was sent for consensus and additional expert opinion and stained, it showed that the AI was indeed correct. Now, the same AI algorithm will have completely different use cases in different environments. At our own institution here at the University of Pittsburgh Medical Center, we have over 40 different facilities. Some of them are academic practices, like downtown here in Pittsburgh, we have 4 academic hospitals, but also throughout the whole state of Pennsylvania, into Ohio, New York, and elsewhere, we have community practices. In our academic setting, we have specialized pathologists who only look at some type of cases. And in our community practice, we have general pathologists who look at all types of cases. And at an academic medical center, if you look to the left, what we have there is a moderate number of cases, but these are very complex cases that get referred to these academic hospitals, which is why we need experts in those hospitals. They would like the use of an AI algorithm to provide automation and efficiency so that they have time to work on their academics. They do not feel that they really need AI for accuracy. They will accept that there may be standardization of care. So everyone will be grading cancers the same if you're given the same yardstick. It's very different in a community pathology practice, where, as you can see on the left, our general pathologists tend to have a lower case volume, less complex cases. In fact, if they have complex cases, they refer those on to the academic hospitals. And so our general pathologists would like, as you can see on the right, something that's quick and easy to use, and they would like diagnostic assistance. They want to know when they go home that they didn't overcall or undercall any cancer case. So they are looking for reassurance from AI. And we would like that too, so that they have expertise right there at the click of a mouse, instead of having to send those cases. So less send outs results in more efficient care and less delay in a diagnosis. Now, a lot of my doctors that I work with tell me that they don't really think AI is necessary in every area, because they can pretty much do many of the things with a microscope already. So I think the real benefit of AI is if you can do something more than a pathologist can do with their microscope. Because at this point in time, a lot of researchers and companies are building algorithms and training them simply to replicate existing classification systems, which are mostly arbitrary and human defined. I think we should rather be training algorithms to outcomes. If we have cytology, we should train to histopathology. If we have histopathology, we should train to subsequent staining of protein patterns and so forth. If we have morphology, we should train to underlying genotype, or even to what the prediction, prognosis, and response to therapy is. Which is why a lot of people are excited about computational staining, which is defined as predicting biomarker expression in tissues based solely on the H&E stained image, the morphology. And there have been several published studies that have validated this already for breast biomarkers, for PD-L1, and even underlying molecular profiling. So while these have been published in proof of concept, I have not yet seen one algorithm available for us in clinical practice, at least not FDA cleared in the US. So for example, if this was my case of a patient who had lung cancer, and you can see on my computer screen is a well-differentiated adenocarcinoma, if I did not have enough tissue, I could not do molecular testing on this particular case, and this patient would then be denied therapy. Or if this patient could not afford to have molecular testing, either insurance didn't pay for it, or they were from a country outside of the US, they could not benefit from molecular testing to find the right drug to treat their cancer, which is what we call personalized medicine. But what if I could just annotate a representative area of that particular tumor, which could be run on premises or in the cloud, and in exchange, I would then get the molecular profile, which could help guide therapy. So I think that's where we should be going, which is where some people are working on, which is where we are investing in our own computational pathology and AI center here at the University of Pittsburgh. Now, in addition to non-generative AI, I'd like to point out that given that generative AI itself has advanced, we are also looking to leverage Gen AI tools in clinical practice. As many of you know, artificial intelligence tools today are capable of generating text, images, code, or any other media you want, such as ChatGPT. Commonly, people are using this for creative writing, summarizing text, data mining, and so forth. You can even create synthetic or new fake data using a Gen AI tool. In pathology, we are working on what we call a PIT-GPT to help automate report generation, to classify diagnoses, and even build synthetic data biobanks. Of course, we're concerned about bias, ethics, hallucinations, as many other people are plagued by generative AI tools too. The reason one would want to create synthetic data is because not only can you use the synthetic data to increase performance of AI training algorithms, but you can also generate teaching sets of uncommon and rare cases that ordinarily you would not have exposure to teach various learner groups. There's a perfect example where in this particular pathology lab in South Africa, where they do not have a lot of access to bladder cancer, so they cannot train people on how to screen for bladder cancer, they created synthetic images, and they had personnel look at these who could not tell the difference between a real or synthetic image. So it has implications for teaching and for training algorithms to enhance performance. Now, as we use these AI algorithms in practice, the following questions have come up, which I have my own opinion about, but I'll share them with you because I'm sure you have an opinion. The first thing is I'm often asked by pathologists and commercial vendors in the space is, what is the right task for AI in pathology? Everyone is looking for that killer app that all pathologists need and that everyone is going to buy, and that of course will make whichever AI startup company rich. I think there are over 1,000 AI algorithms that need to be built today, because you can have many different types of diseases involving many different tissues in many organs, and the tissue prepared in many different ways. So pathologists can come to work with over 1,000 AI algorithms in their head. Can we get to AI where you can actually reach the same level of intelligence? We also are not quite sure yet what the right evidence is for using AI. If there's FDA clearance, is that sufficient? Do people want to see peer-reviewed publications or peer recommendations? Is that enough to convince other pathologists to use the tools? We also have a hard time justifying the return on investment because there's no reimbursement at this point in time. There's no CPT or billing code for AI. And in fact, that has risen some concern because if AI makes a pathologist's job easier, quicker, then there's a potential that they may be reimbursed less and not more for particular cases. As I pointed out, we're not quite sure the best way to deploy the infrastructure from an IT perspective. Should it be in the cloud? How do you integrate it with other systems and so forth? And something that has arisen in our academic hospitals is, should the pathology trainees interact with AI? Some people feel no, because they will be de-skilled. Others feel yes, because they will be the new champions. This is their future. And in my experience, I have allowed trainees access to the AI algorithms, and it turns out that not only are they the best champions, but they also help troubleshoot a lot of issues, and they begin to use the AI for research purposes. My recommendation for validating an AI tool in clinical practice is to approach it from a clinical point of view, which is the far right, not the left. Analytical validation is a very technical thing that the vendor is responsible for when they develop the tool, where they hold out about 1/3 of their data set. And they usually have a very large data set, and it's part of the app development to help meet regulatory standards like FDA clearance. That should not be imposed on a clinical lab. It's also different to technical verification, which is like, once the tool is made, it doesn't help to go to the showroom where where all the features are pointed out, because again, this is very technical, where the lab will work with the vendor that will calibrate their tool on a small data set and fine-tune it and lock it down. And there's only some application to an external data set, but not very large. What you really need to do is on the far right. You need to test drive that in your own environment. That's what clinical validation is. It's a clinical responsibility. The lab is liable for test driving. You don't need a large data set like you did when you first developed the algorithm, just a medium-sized data set, but you have to use a lockdown algorithm. You cannot shift it and have drift, because you can no longer rely on the results, which makes it tricky if you want an adaptive algorithm. But it's important to do that and document that from a compliance perspective. We've also reached the point in medicine and pathology where we have many challenges that we're not quite sure if they should be solved by artificial intelligence on the left or molecular testing on the right. I'll give you one example, which is the common Pap test to screen for cervical cancer. Today, there are AI algorithms. There are about 7 commercial AI algorithms with imaging systems where Pap tests with thousands of cells get analyzed by AI. And there's even one that's FDA cleared. So should you subject a Pap test to AI analysis, which is accurate, rapid, reduces the need for workforce, or should you send the cells off for molecular testing, which a lot of people propose should be done, like PCR for HPV testing? The problem is if you have an HPV negative cancer, you would miss that. So I think maybe going forward, for all the different challenges we have in pathology, we may need a combination of AI and molecular testing. For example, we may use AI to screen out particular cases. So look from the morphology to predict potential underlying molecular abnormalities. And if there's a high probability there is, then only send those samples for molecular testing. Maybe not test all the samples. And the message I give to my pathology team is that I'm not taking the work away from them. They can continue to do their work, like, read cases, which is a high volume, mundane job, and I'll provide them with a tool which will simply augment their work, but not replace them entirely. And so one of the most difficult things in practice for me today is change management, to convince the doctors to adapt to change so that we can practice contemporary medicine and meet and address all those needs that I presented to you in the beginning. So thank you for your attention. And at this point in time, I would be happy to answer any questions if there are from the audience. Are there any questions? I don't see anything in the chat.
Hi, Dr. Pantanowitz, can you hear me?
Is the screen just black?
Let's try this.
Okay. Dr. Pantanowitz, can you hear me?
Yes, I can hear you.
Wonderful talk. I'm wondering if you could talk a little bit about how clinical validation of AI algorithms may look different than, say, validating a new sequencing pipeline or new IHC or anything that pathologists already have experience with validating.
Well, I think in principle it's the same thing. In a lab, all of those should undergo validation. For the prior testing modalities you mentioned, like immunohistochemistry, molecular, usually we do not need a large number of cases. In fact, accrediting agencies like CAP, College of American Pathologists, just require 20 positives and 20 negatives, and human interpretation to look at, if they're positive or negative. I think it's a little more complicated when it comes to AI tools, because I don't know if just 20 positive and 20 negative cases is sufficient. I don't know if just humans, making the interpretation is good enough at this point, subjective versus objective analysis. But it's a great question, and unfortunately, there aren't any standard guidelines that I'm aware of, either in the USA or abroad, where people have, come up with recommendations. And I think the reason that they haven't is because there is insufficient published data out there for people that have used and validated AI algorithms in a true clinical setting to accrue enough evidence so that you can make a recommendation. So at this point, any recommendations would just be based on expert or consensus opinion, not on true published evidence.